All right, the neurologic system. So we talked about this, and it's so important. We've talked about this for every single system. You have to get a baseline. Why is it so important to get a baseline, especially for neuro? So to have that baseline, you're determining later if an acute change does occur, you know what their baseline was and what that change is. So typically those changes in a neuro will require quick intervention. So early detection is key. So again, you always need, always get a baseline, because there has been times where I have heard stories where they didn't get a baseline. Patient had a stroke, doctor comes in, and the doctor goes, "So what were they before?" The nurse goes, I don't know." Okay, well, you are actually causing more damage and more harm to this client because you did not get a baseline. Okay, so the structure and function of our nervous system is divided into two parts. You have your central nervous system, which is your brain and your spinal cord. Then you have your peripheral nervous system, which is going to include all those nerve fibers outside that brain and that spinal cord. So it carries the sensory, the afferent messages to your central nervous system from the sensory receptors. Then there's the motor efferent messages, which will carry from the CNS to the muscles and glands. And also it will do the autonomic messages that govern the internal organs and blood vessels. So just a picture of the components of our central nervous system, which we're going to kind of break all of this down, each one of these topics. So first one, cerebral cortex. So there's your cerebral cortex. It's the cerebrum's outer layer of the nerve cells. So that cerebral cortex is the center of functions for thought, memory, reasoning, sensation, voluntary movement. It's the largest division of the brain. It's divided into two hemispheres, and then each of which are divided into 4 lobes. So the lobes of the cerebral cortex, the frontal lobe, it's going to be dealing with the personality, behavior, emotions, intellectual function. This is, again, the frontal lobe, which is the pink part. The parietal lobe, okay, parietal is the purple. That is more for that sensation, the sensory. Okay, occipital, which is your green, okay, in the back, primarily for our vision, our visual receptor center here. Temporal, which is the orange, that's behind the ear, okay, has auditory reception, a center, taste, and smell. So in the temporal lobe, you have the Wernicke's area. That's going to be associated with that language comprehension. So if a person has damage in this area, okay, there's going to have that receptive aphasia. So the person's hearing sounds, but there's no meaning. So they hear sounds, but then they're talking like a foreign language to me. I have no idea what they're saying to me. So that's when they're having an area or a language comprehension problem in the Wernicke's area. So it's called receptive aphasia. The Broca's area, which is in the frontal lobe, that helps with our motor speech. So if there's an injury there, there's going to be expressive aphasia. So the person cannot talk, okay? The person can understand the language and knows what they want to say, but whatever's coming out of their mouth is just garbled. It makes no sense. So when there's damage to the cerebral cortex, it is deprived by the blood cell, especially when a cerebral artery becomes occluded, such as an ischemic stroke, or when there's vascular bleeding, which is a hemorrhagic stroke. So what do you guys think? What manifestations might you assess if the blood supply to the occipital lobe is impaired? What might you see? What signs and symptoms you might see if the blood supply to the occipital lobe is impaired? Good. Changes to their vision. blurry vision, central vision loss, right, left vision loss, complete vision loss. So here's your central vision loss, and then your left vision loss. All right, so some more components. We have the basal ganglia. So this is initiate and coordinate movement and control of the automatic associated movements of the body. Okay, if you look here on the picture, it's going to be right there. I don't have my scroll. Right there. Okay, the thalamus. Its main relay station were sensory pathways of the spinal cord, cerebellum, and brainstem form synapse. The hypothalamus, that's in control of many functions, many basic functions. Appetite, sex drive, temperature, heart rate, coordination of the autonomic nervous system, stress response, emotional status, blood pressure, sleep, has all these controls. So the cerebellum, okay, it is associated with the coordination of voluntary movements, equilibrium, and muscle tone. Does not initiate but coordinates and smooths movements. So coordinates many different muscles needing to do activities such as playing piano, swimming, juggling. There's different cerebellar function tests for their balance that we could do. So initially we could just observe them walking about 10 to 20 feet, especially in the ER. When I observe their gaits, when I call their name in the waiting room, they walk towards me. I can see if their gait's smooth, rhythmic, effortless, or are they limping, slow, staggered? How are they walking? You can also ask the person to walk a straight line, such as if they're doing a sobriety test, heel to toe, okay? So this is really going to show me how their coordination is. Normally we can walk straight and stay balanced, but if there is a cerebellar issue, then it will display here as well. You can ask them then to walk on their feet, then on their toes, then on their heels, just for a few steps. Then the Romberg test. So the Romberg test, you're going to ask the person to put their feet together, arms to their side, in a stable position, ask them to close their eyes, and then you're going to have them hold this position for about 20 seconds. So usually they're able to do this. You'll see a slight sway, which is expected. But if they start swaying a little bit more than about a 1 inch, okay, you're concerned. You can have them perform shallow knee bends or hop in one place. It just demonstrates how their posture is, their muscle strength, their cerebellar function is. Some individuals, they can't do this because of aging or obesity. The brainstem. So the brainstem is the central core of the brain. It consists of the nerve fibers. So cranial nerve 3 through 12 is originated from the nuclei in the brainstem. The midbrain, the most anterior part of the brainstem, it merges with the thalamus and the hypothalamus. This contains many motor neurons and tracts. The pons, it contains the ascending sensory and descending motor tracts. The medulla, okay, it contains all those fiber tracts containing the brain and spinal cord, has vital autonomic centers such as for respirations, heart, GI function. So if someone has an injury to the brainstem, they're going to have an injury to the respirations, their heart, GI function. Spinal cord. So there's the main highway for ascending, descending fiber tracts that connect the brain to spinal nerves, and it mediates reflexes of posture, control, urination, pain response. So the left cerebral cortex receives the sensory information from and controls motor function on the right side. The right cerebral cortex, likewise, it interacts with the left side of the body. So if your patient has a left cerebral cortex injury, okay, they're going to have right-sided deficits, okay? Same thing. They have a right cerebral cortex injury, they're going to have left-sided deficits. Okay, so the sensory pathways. So if you think of it just like a map, I'm going to have you guys read this on your own. There's just a lot of this stuff is more A&P stuff, but we're going to go over some of these things. But pause it, make sure you read through it. Okay, question. I love questions. The nurse observes that a patient's gait is unsteady and assesses a positive Romberg sign. So again, you have to think about what is a Romberg sign? What does that do? You don't even really need to know because it's saying that they're observing the patient's gait and did a positive Romberg sign. So you already know that the Romberg sign is dealing with their gait. How is their balance? How is their coordination? So now it's asking which area of the brain is most likely affected. So which area of the brain controls balance and coordination? Oops. It was cerebellum. Sorry, I thought it was on this slide. But it's the cerebellum that's going to control it. So reflexes. So basic defense mechanisms of the nervous system. So it's involuntary. So below level conscious control permitting a quick reaction to potentially painful or damaging situations. So there's different types of reflexes. There's DTRs, which is deep tendon reflexes, such as like a knee jerk. Superficial, which is like a corneal reflex. Visceral, pupillary response to light. Pathologic, which is such as the Babinski reflex, so for babies on the plantar of their feet. So DTRs. This is more in an advanced practice, but you guys will be learning this. So you want to have their limbs nice and relaxed and the muscle partially stretched. You're going to stimulate the reflex by directing short, snapping blows of the reflex hammer onto the muscle insertion tendon. You want to compare right to left. So if you're doing the knees, you want to compare that right knee to the left knee, and they should have the same DTR. So they're going to be they're going to be graded on a 4-point scale. So average is about a 2, that's normal. And then 0 is no response, 4 is very brisk. It could indicate a disease, such as like an electrolyte imbalance. So cranial nerves. Cranial nerves enter and exit the brain rather than the spinal cord. So cranial nerves 1 and 2 are from the cerebrum. 3 to 12, they're from the from the brainstem. So there's 12 cranial nerves, okay, supplying primarily head and neck, except the vagus nerve, which travels to the heart, respiratory muscles, stomach, gallbladder. So this is a nice little picture I provided on motor nerves versus sensory nerves. So the motor nerves are going to be blue lined. The sensory will be red. Now some nerves are a mixed nerve, so that's important to know. But there's 12 nerves and we're going to go through each one of them. So now we're going to go through your cranial nerves. So cranial nerve 1 is olfactory. That's a smell. So its unilateral loss of smell could indicate frontal lobe lesion or a tumor in the olfactory tract. So it's really important that we do one nostril at a time. And then bilateral loss could be due to an upper respiratory infection, tobacco use, or rhinitis. Cranial nerve 2. So this is for visual acuity in fields. So this is doing the Snellen chart. And then remember when you guys were in HENT and we talked about doing the peripheral fields. So have you cup your eye and your client's eye, and then you're going to test their peripheral fields. You can also go behind them and see when they can see your fingers. Okay, cranial nerve number 3, 4, and 6. So oculomotor, trochlear, and abducens. This is the EOM, the extraocular movements, which is the 6 cardinal fields of gaze. So also it does PERLA, so pupils equal, round, reactive to light, and accommodation. So you're going to use that pen light, okay? You're going to shine in their eye, and you're going to look, okay, before you shine it, and when it returns, does it come back to the same? And it should come back. So it should be about 3 to 5. I believe your ATI says 3 to 7. Just confirm with your ATI. But those are, it's always going to be a little bit different numbers a little bit. It's just off by like 1 or 2. But 3 to 5 millimeters, that's expected. 7 is pretty large. So if it is 7, it's going to be very dilated. The smaller the number, the smaller it's going to be constricted. The bigger the number, more dilation. So an abnormal nystagmus. So the way to do nystagmus is during the 6 cardinal fields of gaze. So have them look at the pen, and then all you do is ask them, okay, keep your head still, but just look at the pen and move your eyes when I move my pen. When you're moving the pen, excuse me, go nice and slow, because you're looking for nystagmus, okay? And you're going 6 times. So, no pupillary reaction, that is an abnormal. It could mean that there is a brain bleed or a brain injury. No eye movement, okay? Tumor lesions, orbit fracture, etc. Okay, so you can take a look at this. Just want you to read it for a second. So, A, if you look at A, so this is the pupillary reactions and the cerebral compression. So, this is with a brain injury, okay? Maybe there's bleeding or swelling. So the black part here, fluid, swelling, okay? Or any bleeding. Now, because you can tell that it's now pushing that side of the brain in, and then it's causing a shift. You can see how it's pushing over this way. Okay. So initially, we should be normal. Our right and left should be the same, 3 to 5, 3 to 7 millimeters. Then B, okay, so normal, so let's say on the right side, normal constriction. B, slightly reactive is constricted. And then C, slightly reactive, then normal size, unreactive. Now, here's the things that we really become worried. Even at C and B, I'm worried. But when I see D and E, I'm worried. So, they're dilated and unreactive. Then E, fixed, dilated. They don't move. There's no reaction. They are most likely brain dead. Honestly, they're most likely brain dead. So if you have a patient that has fixed dilated pupils and their glaucoma scale is dropping and you have multiple factors, you really got to intervene quickly, very, very quickly. So this is just an example of the 6 cardinal fields of gaze. So initially you're going to look, you're going to have your patient look forward, go up, go down, go to the side. And remember, these are all different nerves, 3, 4, and 6. Okay. So cranial nerve number 5, so this is the light touch sensation to the face, and then bite down and open the mouth against resistance or chewing. So what you're going to do is have your patient close their eyes. They're just going to ask me, like, do you feel this? Does this feel the same or different? And then you can take that cotton swab or your finger, and you can just touch and be like, can you tell me where I'm touching? And you just touch different areas and make sure that they can actually feel that area. Next is you're going to go near the TMJ, so trigeminal TMJ, and you're going to have them bite down, open their mouth, and you should be able to feel that joint open and close. Number 7 is the facial. So this is taste, and then also the facial movements. So again, taste we really don't do, but facial movements we do all the time. So I'm going to have my patient smile, and I want to see their teeth. So if they go, I can't really see if they're symmetric. That's something I have to see. I have to see that symmetry here because I want to see the facial folds here. And then I want to see everything else is asymmetric. So smile, frown, puff out the cheeks. And when their cheeks are puffed, you can push down on their cheeks and the air should express out equally. Close our eyes really tightly, okay? And some doctors will try and force them open. You can, cannot, doesn't matter. And then raise your eyebrows up. I know it's not here, but you should have them raise their eyebrows up because, again, you're looking at the creases on their forehead to see if it's symmetric. Auditory is number 8, so that's the hearing. So it's a whisper test. So go behind your patient. So if you see the little picture down here, it says, now relax, and the doctor will begin your hearing test in just a moment. Ding, ding. No, not exactly. You're going to go behind them, and you're just going to have them close one ear, okay, and just go 1, 2, 3, or ABC, something simple, and then ABC, something very simple that they can hear. And then balance. You're going to do their balance. So that's with the Romberg test. And we talked about the Romberg test. So again, you're going to have them stand up straight as long as they can. Have their arms to their side, feet together as close as they can. Close their eyes. And then you're just going on the side of them. I know your book says to go in front of them. But if you think about it, your patient's going to fall probably backwards or sideways. And I don't want them falling on me. I'd rather be able to catch them and see where they're going to be landing. So I always want to stand on the side, have one hand in front of their chest, one hand on their back, not touching them, but just about a couple inches. And I'm just seeing if they have a sway, okay? There should be a slight sway, very slight, but if they're more than that 1 inch, 2 inches, then, okay, we're really unbalanced. And ask them how they're doing, especially when they have their eyes closed. They could be lightheaded, dizziness, nauseous. They could be exhibiting some other symptoms. So make sure you ask them, how are you feeling right now? They're like, oh, I feel really dizzy. If they feel really dizzy, I don't want to continue with the test because then I just figure it out. Okay, well, I just figured out once they close their eyes, they get really dizzy. Now, when they say they're getting dizzy, I want to know what type of dizziness. Is it the room is spinning or do they feel like they're on a boat? 2 different types of dizziness. So this is the facial. She's having him smile and raise his eyebrows up a little bit. So you can see that he is not symmetric. Okay, the way, again, look at the forehead, look at the creases under the eye, and look at your facial folds here. Okay, and then also you can see the smile. Now, because the mouth is open, I'm going to be able to get a better assessment on the symmetry. Okay, number 9, glossopharyngeal. So number 9, 10 go together, and you could also put number 12 together with this one. Okay, so glossopharyngeal is number 9, vagus is number 10, hypoglossal is number 12. So for the glossopharyngeal, you can do taste, the swallowing, gag reflex, and speech. So you're going to watch the uvula move up and down. So when you put in your tongue blade for your gag reflex, you're going to have them say, ah, and you're going to see that uvula move up and down. So with the vagus, it goes with speech as well. So it talks with hoarseness, the ability to swallow, gag reflex. So That's why I say vagus and glossopharyngeal, they really collide together. But vagus is really about the speech, and then glossopharyngeal is about the gag reflex and the swallowing. But when we talk without hoarseness, we want to make sure that they are talking clearly. So what you can ask them to do is say light, tight, dynamite. Okay, when you're doing the glossopharyngeal and the vagus nerve, because then you're seeing, are they articulating the words and are they able to repeat it back? Cranial nerve number 11 is your spinal accessory. So with resistance, you'll put your hand on their face and ask them to push against your hand. Same thing over here. And then you're going to ask them to do ear to shoulder. You want to see, okay, are they able to go all the way over? Then, again, you're going to have them shrug their shoulders, but you're going to put your hands lightly on them, just slight resistance, and just have them shrug their shoulders. You want to see if it feels the same. Is it symmetric? Cranial nerve number 12 is hypoglossal, so this is the tongue movement. So as you see here, the tongue is more deviated to the left side, okay? So you can tell that it is deviated to the left because it has all these creases here, and then it's nice and smooth over here. So when your patient is sticking their tongue out, especially for your gag reflex, you can just test it right then and there, right? You don't have to do this all on its own. So you're having them stick out their tongue, and you're noting if it's midline or if it's deviated to the left or to the right. And then you're going to have them move it side to side. Are they able to move it side to side? And then up and down, just once. That's all you have to do. Then you can take your tongue blade for your gag reflex, have them say and then test their gag and test their swallow. So you can do vagus, glossopharyngeal, and hypoglossal all at once. So here are some popular mnemonics to memorize. So one is only overgrown orangutans try to aggravate fat vagrants getting vodka and hamburgers. There's multiple, so you guys can remember. Okay, so here's a question. The nurse is performing a neuro exam and is assessing the client's cerebral function. Which of the following assessments should the nurse perform to test the client's balance? D. Heel to walk toe is used to verify balance as the client walks a straight line toe to heel. Okay. A nurse is assessing a client's cranial nerves as part of a neurological examination. Which of the following actions should the nurse take to assess cranial nerve 3? So you would have to know cranial nerve 3, okay? So we know that that's the oculomotor nerve. Does that do visual acuity, facial symmetry, gag reflex, or pupillary response to light? It's D. It is for Perla. Testing acuity is cranial nerve number 2, optic. Observing facial symmetry is cranial nerve number 7, facial. Assessing gag reflex is cranial nerve number 9, hypoglossal. Okay, so mental status. We talked about this in very early on, but we're coming back to it. So we're looking at their level of consciousness. Okay, their normal or expected is alert and oriented times 4. So alertness, spontaneously responsive. Okay, you walk into the room and they respond straight to you. They look at you, they're making eye contact. Lethargic, so they open their eyes, but they seem drowsy. Okay, abundant, so they respond to light touch, they're confused, and they're slow to respond. Stuporous, so it's only respond to painful stimuli. They may not respond verbally. Comatose, there's no response. So these are all different types of mental status. Okay, so alert, lethargic, abundant, stuporous, or comatose. Now with comatose, there's no response. Now there's different types. So there's decorticate, rigidity, and then there's decerebrate rigidity. So decorticate rigidity, if you look at it, core, okay? Everything is fixed in, okay? They have a plantar flexed, internal rotation of their legs, their elbows are flexed, they are in this position where their wrists are flexed, they're coming together, their arms are abducted, okay? They're close to each other. Now, this indicates that there is a hemispheric lesion to the cerebral cortex. Now, decerebrate, I think of celebration, okay? Everything is out, okay? Especially the arms. The arms aren't tucked in to the core. They're now outwards, okay? Decerebrate. So a decerebrate rigidity, this is more ominous than the decorticate, so it indicates that there's a lesion on the brainstem at the midbrain or upper pons. So the head is arched, the arms and legs are extended. So the plantars are still flexed, the wrists are flexed, but the arms are extended. They're still close together, but instead of being corticate, okay, they're decerebrate. Okay, so the way I was taught and the way I've always remembered it is decorticate. Okay, so it's actually, I want to say it the wrong way, but it's concerning, but it's not, I'm trying to figure out the right way to say this. So decerebrate, because it's to the core, that there's an injury on the brainstem. Keep in mind, what does the brainstem do? If there's an injury to the brainstem, it's not a good outcome. You'll have a worse outcome with patients who are going to decerebrate than decorticate, okay? So the Glasgow scale, you have eye-opening verbal response and motor response. The Glasgow scale is used every time you do a neuro assessment, and it's just to see how their mental status is. Are they spontaneously opening their eyes? Do they respond to verbal response? Are they oriented? And for motor response, are they obeying commands? Now, they get a score for each one. So let's say you have a patient that comes in and their eye opening is only to pressure. Okay, so when you touch them, then they get a 2. Okay. When you touch them, they respond, they say something, and it's kind of confusing. So maybe it's just sounds. Okay, they're just like, okay, just sounds. That's a 2. But they're able to have normal flexion. Okay, they're able to actually flex, unflex, like relax. They're able to kind of obey commands, but not completely. This is more judgmental. You can give them a 4 or 5, okay? Anything less than 8, okay, you really need to intubate, okay? You'll always hear that, less than 8, intubate. So it's severe. Their Glasgow scale is very low. There could have been a severe head injury or they're in a coma already. 9 to 12, there could have been a moderate head injury, okay? And that's why they're just off a little bit, but they're about to kiss that severe side. And then expected should be a 15. Now, maybe 13, depending on the age and the type of person it is. But if they have a Glasgow scale of 3, so none, none, none on all 3 options, it's either they're in a deep, deep coma or they have passed on. Okay, so if you have a patient that is intubated, you're still going to do a Glasgow scale. You're still going to see if they respond to pain. They shouldn't if they're intubated and sedated. But if you're trying to actually extubate them, so take the tube out of them so they can breathe on their own, you are going to continue to do this because you want to see if they respond to painful stimuli. Are they moving their arms freely? How are they responding? Do they open their eyes as well? Okay, so for our aging adults, we talked about how while we're getting older, we're going to start to decrease a lot of our functions. Our blood pressure, our systolic blood pressure, increases, but with our neurofunction, there's an atrophy with a steady loss of the neuron structure in the brain and the spinal cord. So patients over 65 start showing that decreased muscle strength, loss of muscle tone in the face, neck, around their spine, impaired fine coordination and agility, loss of vibratory sense at the ankle, decreased or absent Achilles reflex, irregular pupil shape, decreased pupillary response, reflexes, I mean. Some clients have short-term memory decline, so they're not able to recall that short-term memory. Delirium in older adults is very common with infection. So they have a slower reaction time. So if they just dropped a pen, it takes a lot slower than we would just to have that quick reaction time. And it's due because of the velocity of the nerve conduction is decreased. They have diminished sensation of touch, pain, taste, and smell because there's that increased delay at the synapse. Their motor system may show general slowing down of movement. So again, that muscle strength and agility is decreased. So those range of motion exercises is very important for them. They have fewer brain cells, smaller brain volume, deteriorating nerve cells, progressive decrease in the cerebral blood flow, oxygen consumption. It can cause dizziness and loss of balance. And these patients, because of all of these factors, they're at a greater risk for depression. So some subjective questions. So I'm going to kind of zoom through this because I don't want to just waste the entire YouTube time and just asking the questions. But I want you guys to look at these questions because these are just type of questions that you can ask. So if they have a headache, you're going to PQRS it. If they have a head injury, have they ever had a head injury? What part of the head was it? They need to describe it. Did they lose consciousness? For how long? If they have any dizziness, we've talked about this multiple times. So I want to have them tell me, okay, do they feel lightheaded? Do they feel like they're on a boat? Do they feel like they're spinning? How do they feel? So if they ever feel like a sensation called vertigo, that rotational spinning sensation, they're going to feel like everything is spinning. They're just like constantly spinning. Does it come on suddenly or gradually? If they have a history of seizures, because that's a neuro disorder. Have they ever had convulsions? When do they start? How often do they occur? Do they take medicine for that? Is there any participating factors that cause this seizure to start? Do they have an aura? Do they have an aura? What do I mean by do they have an aura? So an aura is actually like a sensation or a warning sign for them that, oh, I'm about to have a seizure. So they get this aura. Some people smell a certain smell. Some people see a flashing light. Some people start twitching their fingers, and that's their warning sign. So they have that aura. Not every patient has an aura, but you can always ask them when they come into your room. So when you have seizures, do you get an aura? Because if they do, then you can be aware of that aura. So when they do say, hey, I just smelled burned tire, then maybe that's their aura. They're like, okay, get ready. Like, we'll get everything in set. So when you do have that, hopefully you don't have that seizure. But if you do, we know what to do for you. So a seizure. So after the seizure, it's called the postictal phase. So how are they? So usually after a seizure, they come to. They're able to wake up a little bit, and then they're a little foggy at first, but they should be able to become oriented after a few minutes. Now, some people's postictal phase will last days, hours, but it all depends on how severe their case is. Now, after their seizure, they're exhausted. Their brain was literally just shaking. They're exhausted. A lot of times they just rest and they don't want to do anything. And that's how it should be, because you need to have the brain rest. The brain was literally just shaking and it was convulsing and it is exhausted. You need to have them be in a resting state. So turn the lights down. If they're having seizures and it's affecting their daily life and occupation, ask them how are they dealing with it. Tremors. So especially in our older adults, they get those senile tremors. So does that affect their daily activity? Weakness. So their weakness is in both sides. Where is the weakness? How often is the weakness? In coordination, do they have any problems walking, falling? How often do they fall? Do their legs just give out? Numbness or tingling. Okay, when did it start? Where do you feel it? Does it occur with an activity? Does it ever feel like pins and needles? So, because then you have to differentiate. So, let's say someone has right arm numbness and tingling occasionally when they sleep. That could be carpal tunnel, could be a pinched nerve. But if they wake up and an hour after they've woken up, they start having numbness and it's not going away and they were just sitting there, okay, we have to rule out possibly a stroke. Difficulty swallowing. So do they have problems swallowing any solids or liquids? Have they experienced any excessive saliva or drooling? Do they have a difficult time speaking? Do they have any history of a stroke, spinal cord injury, meningitis, esophagitis, congenital defect, or any alcoholism? How's their environment, their occupational hazards? Do they have any? Are they exposed to any occupational hazards? Are they taking medications? How much alcohol do they drink? Do they drink alcohol? Do they take any medications that are mood altering? Or do they use other drugs? So if your patient complains about any dizziness, I want to know, does it occur when they first sit up, when they stand? Does it when they move their head? Is it after they eat? Does anything help, like such as if they take medicine, does that help? For men, do they have to get up at night and then feel faint while standing to urinate? What safety modifications have they applied at home due to this dizziness? Have they had a memory change or a change in their mental function? Was it sudden or gradual? Have they noticed any tremors? So those senile tremors in their hands. How's their anxiety, activity, rest? Have they had any sudden vision changes or fleeting blindness? Does it occur with weakness? Did they have any loss of consciousness? So when we're preparing for a neurological exam, we're not only just getting that subjective, but we're now going to get this objective data. So you want to do a complete neurologic examination of people who have any neurologic concerns, such as a headache, weakness, loss of coordination, who have shown signs of any dysfunction. You want to also perform a recheck on them. So reassess them periodically because they can always change. So integrate the steps of the neurological examination with the examination of the particular part of the body. So when we're assessing the head, we're going to do the cranial nerves that are assessing the head and neck. Test those superficial abdominal reflexes while assessing the abdomen. So you're going to do that whole head to toe function. So follow that sequence for a complete neurologic examination. So first you got to figure out their mental status. Cranial nerves, how's their motor system, their sensory system, and then their reflexes. So the equipment that you'll need is a pen light, a tongue blade, cotton swab, cotton ball, a tuning fork, and a percussion hammer. Now, if you don't, because I don't in my home right now, I don't have a tuning fork or a percussion hammer, I don't have a cotton swab, cotton ball, and then a lot of times in healthcare, like in your setting, you may not be able to find that hammer or find the tuning fork, but you can always improvise. So to do the hammer, you honestly could actually, and that's for your deep tendon reflexes, you could really use your hand. As long as you're finding the reflex, you can do it. Cotton ball, cotton swab, that's for that sensory, so you can just use your hands, use your gloves. So when we're looking at the motor system, we it's really similar to the musculoskeletal. So you're testing out their strength. How's the tone of the muscles? Do they have any involuntary movements? So we're going to be testing their coordination and their skilled movements. So rapid alternative movements, RAM. You're going to ask the patient to actually pat their knees, just like if you're doing pat a cake. So have them pat their knees, and I'm hoping you can see this. I'm going to treat this as my knees. So we're just going to have them pat back and forth and ask them to do it as fast as they can. You want to see if they're equal turning and is it rhythmic. Then you're going to have the person take their thumb and their fingers and just touch each finger with the thumb. How's their coordination? Okay. Next is finger to finger. So with their eyes open, the person who's testing them, they're going to ask them, okay, can you touch my finger, touch your nose, okay? And then they're moving the finger around because you want to see, can they follow? It's kind of hard to do on your own. Can they follow your finger? Heel to shin test. So this is when you're taking your heel, okay? I'm going to say this is my heel and this is my shin. Take the heel and you're rubbing it all the way up to the knee, all the way down towards the ankle. And you want to see, are they doing this rhythmic and is it smooth? Perform all four, or sensory function, perform on all the extremities. So you're going to do pain sensations. You could do, you can grab something slightly sharp and just kind of touch, be like, okay. So you could actually, I believe the ATI video breaks. I'm not sure if they break it, but what you could do is you could literally break the tongue blade in half. One side is soft, other side is sharp, and you can literally just rotate and ask your patient, sharp or dull, sharp or dull. Vibration, so you're going to be using that with the tuning fork. Now, light touch, so this is where you are going to be just touching them and be like, okay, can you feel that? Does it feel the same? Do you feel that? Does it feel the same? Another test we can do is discrimination. It's a 2-point discrimination. Test ability to distinguish separation of two simultaneous pinpoints on the skin. You're going to compare bilaterally, so you pinpoint to two different parts, and then they'll identify where you're at. Stereogenesis, it's going to be able to, you'll give them a familiar object in their hand, their eyes are closed, and then they, just by touch, they get to figure out what it is. So if you give them a penny, okay, they'll be able to touch and feel the size of it, the weight of it, and then they can determine what it is. Graph aesthesia, so this is where you have their eyes closed, and then you just write like a number or a letter, and they have the ability to read it. So with the testing reflexes, so this is the deep tendon reflexes, you're going to assess these bilaterally and compare results symmetric. Are they symmetric? So I'm not going to go too deeply into this. We're going to talk more about this in class, but I would like you guys to watch this YouTube video. So when we are doing our neurological reassessments, we really want to look at what their baseline was and see if they're still at their baseline getting better or getting worse. So signs of increasing intracranial pressure signal impending cerebral disaster could lead to death and require early and prompt interventions. So some signs and symptoms of increased intracranial pressure, what do you think they are? They're going to have a change of their level of consciousness. Their eyes are going to have pupillary changes, so they could be unequal. They could have a headache, vomiting, changes in their speech, decreased motor function. Their posture will change, so they could go to decorticate. Okay, so this is when they're posturing in. Decerebrate, this is when they're posturing out. Flaccid, there's no movement. Changes in their vital signs. They could have seizures as well. So you really want to look at their level of consciousness. How's their motor function, their pupillary response, check their vital signs, do a full set of vital signs. So level of consciousness, is there a change in the low conscious is the most important factor in this examination, that motor function. You're seeing if they can just follow those commands. So again, with that Glasgow scale, at the bottom, we talk about that again. So it's a quantitative tool to assess for level of consciousness. Those pupillary response. So you have to note the size and area symmetry for both pupils. Vital signs, so establish that baseline and keep monitoring them. So I would like you to pause. This is just sample charting, which is subjective data. This is objective data, so it gives you a good idea on how we can document on charting. All right, so some abnormalities. I'm going to kind of skim through these, but I would like you guys to look at this, and if there's anything you don't know, make sure you look it up. So olfactory, so if they can't smell, anosmia. Optic nerve, so optic nerve is testing their vision. So we talked about something that's unexpected, so the absent light reflex. They could have that absent central vision or a defect in their peripheral vision. Ocular motor, trochlear, excuse me. So ocular motor, so they could have a dilated pupil, their eye turns out and slightly down, failure to move the eye up, in, and down. There's no light reflex. The trochlear, there's a failure for the eye to go down and out. Trigeminal, there's an absence of touch. Okay, there's no blinking. Their TMJ, they have a weakness in their temporalis muscle. Abducens, so they fail to move laterally, or they also have nystagmus. Facial nerve, absent or asymmetric facial movement if they have a loss of taste. Acoustic, so if they have a decrease or a loss of hearing, also with their balance, if they're very unsteady. Glossopharyngeal, so there's no gag reflex. Vagus, so the uvula deviates to the side, no gag. The voice is very hoarse or brassy. They have dysphagia, fluid regurgitates through the nose if they're drooling. Spinal accessory nerve, so there's an absent movement of sternocleidomastoid or the trapezius muscles. Hypoglossal, so it's not midline, it deviates. So some abnormalities in the muscle tone. So we talked about rigidity, flaccid, muscle movement, so it could be paralysis, could be tremors, intention tremors, rest tremors. They could have a tic, or there was a seizure disorder. Gaits, so they could have that scissors where they walk literally like a scissor. Waddling, short leg, they could have a foot drop. Some common patterns of motor system dysfunction. So they could have cerebral palsy, muscular dystrophy, hemiplegia. They could have paraplegia, multiple sclerosis. These are all motor system dysfunctions. Common patterns of sensory loss, so they could have peripheral neuropathy. It could be from diabetes. So the loss of sensation, loss is most severe distally at the feet and hands. Individual nerves or roots, so decrease of the all sensory modalities corresponds to the distribution of the involved nerve. So complete transection of the spinal cord, so complete loss of all the sensory modalities below that level of lesion. So they could be paralyzed. The thalamus, so this means that they have loss of that sensory modalities on the face, arm, and leg. Cortex, loss of discrimination on the contralateral side.